So just to say that this is our third webinar within the heart failure series. It's great to see so many people that are on the call this afternoon. Our first webinar was back in July, and we had Amit Foot and Jack Lyon with us, and Jack was setting the scene for heart failure priorities for North East and North Cumbria Integrated Care Board, and Amit gave a really good overview of heart failure, including diagnosis and management. We had our second heart failure webinar in September, and that focused on the fact that we have developed some CDRC searches for heart failure for primary care for EMIS and System 1. These are currently not widely available. We're currently testing them to make sure they work, but hopefully in the coming months we'll come back and communicate with you that they are free to use and widely available. And alongside the CDRC element, we had Pumping Marvellous, who came along to speak about their Beat Heart Failure campaign. So today, just to run through the agenda, we've got Trudy Hunt and Stephanie right here to speak through heart failure at home and the virtual wards project and heart failure cardiac rehab. So thank you very much, Trudy and Stephanie, for taking the time to come and share your expertise with us. So I'll hand it over to Trudy now.
Okay, well, good afternoon, everybody, and just to say thank you for giving us the opportunity to showcase our pathway for remote monitoring for those patients diagnosed with heart failure. I just want to give a thank you to NHS England, who helped with this presentation. It's actually a case study on Futures NHS, where you can take a look at it on there as well. Have obviously changed a few things because things are moving quite quickly with the project, and now basically the integration of this new way of working is usual care for us. So next slide. So really a summary of the project. So we all know, like, living with heart failure is becoming increasingly common, and from our point of view at North Tees and Hartlepool, which I'll just say that we have actually amalgamated with South Tees, so we University Hospitals of Tees now. So and we are mentoring South Tees with this project as well. So from our point of view, we just possibly post-COVID, the amount of referrals just went sky high, and we just really needed a new way of working to try and capture all of our patients in a timely and effective way. So we put in for the managing heart failure at home with NHS England, and we were successful with that, and that was really at the key point where we've established this new way of working, and it's been instrumental in reducing face-to-face appointments and saving clinical time and obviously improving patient outcomes. Next slide. So we all know what the challenge is really with heart failure. Living with heart failure is becoming increasingly common. Lots of people with heart failure, and obviously due to the aging population. That's the statistics there, where we have 1 in 35 people 65 to 74 years of age. There's 1 in 15 people 75 to 84 years of age, and just over 1 in 7 people will have heart failure 85 years and over. So of course, with the aging population, like the referrals to all our services is just growing and growing and growing. And so again, this is why we needed a new way of working to be able to see all of these patients and give them the treatment according to the NICE guidelines. Obviously, we were in an area of deprivation, or we are in an area of deprivation, and life expectancy is less than the national average across our area. Next slide. So we are obviously a well-established team. We've been we developed the team back in the service back in 2004, so a long time ago, and it really is integral to the care of heart failure patients. We have quite a strict inclusion criteria, which we've kept all along, but obviously with the new NICE guidelines, we're going to have to expand on the ejection fraction of patients that we'll be seeing. So we really wanted this new way of working across some various other teams as well, so it's more integrated. But as we've gone along, which you'll see from when I go through the presentation, we're actually a lot more in-house, so we can actually give lots of the services that we offer to the patients through the heart failure service. But when we first started, we had the integrated single point of access where they have a clinical triage system, and we also have the Home First team where we had the digital champions, which will all come together as I go on. So next slide, please. So with the Managing Heart Failure at Home project through NHS England, there was a phase 1 which was started back in 2021. Phase 2, so where they found the findings from the demonstrator sites and they consolidated all of the change. And then we came in phase 3 where we were part of the early adopter sites. So we were one of 10 sites that started the project then. So it's an approach which really aims for people diagnosed with heart failure and their carers to manage the condition at home. And obviously with the development of treatments and things and the titration of medications and the 4-pillar approach, you know, we needed a new way because we just didn't have clinic appointments. We didn't have clinical time to be able to give these treatments in a timely way. So the 3 main parts of this is personalised care. There was a lot of emphasis on the fact that the patients are taking control of their own condition. It's through remote support and monitoring, and I'll show you how we did that as we go along, and through integrated care. So working with other teams within the trust to ensure that we've primarily developed a service that we can move on and make it more in-house. So these elements obviously give a high quality pathway of care from diagnosis to death. They reduce unnecessary hospitalizations and facilitate early discharge from hospital. And as we go along, I'll show you how we've developed our virtual wards. Next slide, please. So our approach basically was started back in September 2022, and we started the project in May 2023. I'll go through sort of some of the challenges that we had actually setting up the service. But the ambition was to make care more accessible by helping patients effectively manage their heart failure treatment without multiple clinic appointments. We were noticing that we were getting a lot of DNAs of younger patients who were working and they just weren't attending the clinic appointments. We wanted to improve the management of all patients diagnosed with heart failure, and our inclusion criteria at that point was with an ejection fraction less than 46%. We would also consider heart failure with preserved ejection fraction if requested by the cardiologists. As you know, they're renowned for needing a lot of input with diuretic therapy and things. So increase the number of patients who can be monitored at home effectively, support timely hospital discharges. We are a team of nurses who, specialist nurses who work across acute and primary care. So we actually have an in-reach service as well. So we're picking up patients in the hospital also. Improve service capacity and efficiency in terms of time scales when responding to primary care patients. So if it was requested, somebody who might have been on our caseload before, we could see them again if necessary, if they were developing symptoms. So the Doctor project was a collaborative approach with a single point of access and the clinical triage team with a single point of access. Without those services to start the project, we wouldn't have been able to do it. So it was with the fact that we you can't. We felt that we couldn't set up this the remote monitoring service alone. We had to have other services involved to help us. So we used quite a lot of the money that we got to up um, the whole time equivalents within various services, not only our own service. So I did an extra day. They had like the single point of excess. We give them more money to get more admin. We use the Home First team. We developed a role called a digital champion. So they're the people who go out and give the patients the equipment, and they sort out any like digital problems that the patients might have, like input and readings and things, which is a major challenge. And also with the clinical triage nurses within the integrated single point of access. They're nurses who pick up the alerts. So when it goes onto the platform, and the platform we used was Health Call, they would pick up the alerts. We felt within the service we would not have the capacity to monitor an email where there was alerts dropping in from the Health Call platform. Next slide, please. Hopefully it'll all come together. You'll be thinking, oh, it's quite confusing about like sort of all of the different roles. But basically, the heart failure nurse identifies a patient for remote monitoring. A referral sent to the single point of access where they would put the patients onto the digital platform, so onto Health Call. The SPA would request the digital champions from the Home First team to go out to the patients and provide the kit and train and educate the patients on how to input the readings onto the digital platform, which was basically on if the patients have a Android phone, there's an app. If they had an iPhone, so Apple phone, they would be given a tablet, and they would be shown how to use the tablets, input the readings, and then they would arrange with the heart failure specialist nurses when monitoring was going to take place. So, 10 o'clock on a Monday morning, or I wanted to give put readings in 10 o'clock every day, or put them in 3 times a day. You could do really what you wanted with the patients. Next slide, please. So this is what the platform looks like. So this would be a patient who's been recording their vital signs, and you can see that we can look at systolic blood pressure, diastolic blood pressure, heart rate. We don't tend to use temperature. We don't use respiratory rate. We use oxygen saturations, and we can also record weight. So with those parameters, we set the thresholds. So we wouldn't want somebody's blood pressure to go above 140 systolic, and 50 diastolic, heart rate not too high, not too low. So we can set the parameters and the thresholds. And if the patients put the readings in and they went outside of those thresholds, then obviously there's an alert comes through onto an email, and that's actioned. And there's really strict, we have a SOP where we have very strict escalation procedures on what to do. We have a RAG rating, red, amber, green, and the escalation procedures are according to how far out of the parameters that the patient's readings are. Next slide, please. So the role description, really, one of the biggest achievements of the whole thing was were digital champions, because we found one of the challenges is basically registering the patient, getting the patient onboarded onto the platform, and getting them to use the equipment safely and effectively, and what to do if there's any problems. If it was one of the nurses having to do all of that, it would take up a huge amount of time. So of course, then that would just like scoop her everything. So really, the digital champion role's been pivotal to the whole thing. So these are two healthcare assistants, digital champions, who are there. Basically, we obviously can use them for other tasks and things, and other care other roles, but one of the main roles is to onboard patients and offboard patients, look after the equipment and make sure everything's going along well. The equipment that we have, we use a live cause for those in atrial fibrillation. We have blood pressure monitors, a pulse oximeter, and we never did buy scales because the scales were hugely expensive. So we basically ask the patients if they have scales. If not, we can the digital champions will carry scales and do weights as necessary. Next slide, please. So as time went on, we were really successful with the first phase for the early adopter. And so then we put another bid in for extra money to become an accelerator site. So what we did with that was we wanted to try and absorb the project into the team so it would become just usual business. So we the additional funding went to a digital management system 1 unit. At the moment, we can integrate with System 1 and the health call system, but they don't marry up. So we have to, obviously the patients are putting in we can't take the readings off health call and they don't automatically go into System 1. So there's lots of work around that. Leadership over the project. I think with something like this, that was a new way of working. You needed a leader just to really keep the momentum going. If you didn't have somebody saying, right, make sure that you're looking for patients who can go onto the remote monitoring, it tends to fall off a little bit. So it's just keeping the momentum going. We had to invest in new kit. We wanted additional Band 3 HCAs for this digital champion role and overall resilience. They now do phlebotomy and things like that. Additional Band 6. New pathways and flow for the project. Obviously, rapid titration came along, so that's been really successful, and we've been able to integrate that within the remote monitoring pathway. We also have a very successful IV furosemide pathway in the community, which we've had for about 6 years. So that works really well with remote monitoring. And obviously, as we're moving along towards a virtual ward, that's worked really, really well. And we're also doing a research project around subcutaneous furosemide. We have also developed weekend working, so we have a 7-day week service now, which has worked really, really well. And we also mentor South Tees as part of our amalgamation, but that was actually part of the accelerator site where we would mentor another trust. We developed a questionnaire that we could put onto the platform. So it would be ask more individual questions like, are your ankles more swollen than yesterday? Or do you feel your breathing is got worse than when you last spoke to your heart failure nurse? Do you feel bloated? So it was more questions around more individualized things rather than just blood pressure, heart rate, and weight, and oxygen saturations. And we've also rolled out the remote monitoring to cardiac rehabilitation, which has proven really successful as well. And that's for titration of medications post-MI. Next slide, please. Anybody who's done a NHS England project will know that there's lots of data collected, and we had this huge database that we collected, and all of the sites have collected as well. So MTech Access put all of that evaluation together, and the key findings across the whole pilot were patients experienced an improvement in health-related quality of life, heart failure-related symptoms and ability to manage their heart failure. And they also experienced a reduction in the use of the primary care services. We looked at a lot of work around how many times the patient went to the GP prior to being placed onto the remote monitoring, and then post. Many test sites saw a reduction in patient use of secondary care services. So, of course, less admissions because we were picking up symptoms a lot earlier. We were getting people out of hospital a lot earlier and they weren't being readmitted. And of course, with a 7-day working, that's made a huge difference as well, where we're actively looking for patients to bring out of hospital. And also we can see patients on a weekend in the community to ensure that they're doing okay, or if they're on our virtual ward, that they're seen every day. So overall, managing heart failure at home is delivering value for patients, improving their quality of life and clinical well-being, while also likely to be reducing GP and nurse resource use in primary care. But they did obviously look, there's further investigation needed to determine whether secondary care resource usage reduces over time. Obviously, there's lots of more information there that you can read when you access the slides if you wish to do so. Next slide, please. So our results. So basically, what we've actively try to get more real life data just for our service. So as I said earlier, we were really concerned about DNAs. We were concerned that our caseload had increased, and that we weren't able to see patients as quickly as we wanted to. Our aim, our goal is we would see a new patient within 7 days, and that was getting it was more towards 2-3 weeks, and that's not good for somebody with severe heart failure. So we really needed to try and find a new way of grabbing hold of these patients and getting treatment as soon as possible. So we've always done performance figures, which we've done for years and years and years. And so we were like comparing against sort of those performance figures and what we were seeing. So we had an increase in caseload by 10.45% in the years 2022 to 23 to 24, 25. We saw a decrease in DNAs by 15.16% when using the remote monitoring. We decreased in face-to-face contacts by 9.72%, and you can see we increased our non-face-to-face contacts by 37.4%. So when we equated that out to face-to-face, we saved over 165 hours due to virtual clinics. 96% of appointments for 100 patients were virtual. So this is all of our patients that were on the remote monitoring. Obviously, we would do an initial assessment and then the other assessments would be virtual if possible. But not needless to say that if we need to see a patient face to face, we would. We were getting 17.5 new referrals per month. So of course, again, the new way of working really tried to stem that so we could see all of the patients. 6% of hospital admissions up to six months post, so that we saw a reduction in hospital admissions and a decrease in DNAs. Next slide, please. Outcomes would be probably the same, but would take a lot longer. So 44 patients of the 100 had repeat echoes. 19 of the ejection fractions improved to 50 to 55%. For those who needed the repeat echo, so they will be what are severe heart failure patients. 14 of the ejection fractions improved and 11 were persistent severe. As I say, the outcomes would be probably the same, but would take a lot longer to titrate medications and things. We were finding that we were reaching optimum sort of titration of medications, 4-pillar approach, rapid titration in about 9.9 weeks, where sometimes that could take up to, 20, 25, 28 weeks. So we're seeing a big change in that. And I know Stephanie's going to talk about cardiac rehabilitation, try to look at what, patients who undertook cardiac rehab. Still 50%, it's a lot of work still needs to be done on ensuring that patients are at least offered cardiac rehabilitation. And of course, mean age was 61. We were age range from 30 to 84. So we would never discriminated with age. So it didn't matter how old. I think we've just put one on who's 93. We've onboarded a patient who's 93. And sometimes they can be much better than I can on mobile phones and things. So next slide, please. So ongoing benefits speak for themselves, really. We've established the IV furosemide, which was done a long time ago, so we can actually like sort of make sure that that's more efficient. 7-day work, and the staff benefits, that we get a lot of achievement, and we feel like we've done something, like the achievement from doing something new and a new way of working. So that's really like sort of like lifted the team. As such, we knew about the rapid titration, and of course we've got the new NICE guidelines for the 46 to 49%, and we really do feel as though this would be a really good way of capturing those patients and getting them onto the medications necessary. We've achieved like lots of things through integration, and like moving the pathway along so it becomes more in-house and more usual care. And we've had lots of really, really good feedback from the patients. Great service and reassuring. They always felt, I think the patients feel supported, that they'll always have somebody at the end of the phone. And of course, if they don't feel well, they can put ad hoc readings in as well, which would be, if they're alerted, they would be monitored as well and action taken. I couldn't believe that when I was inputting my readings wrong, someone was straight on the phone asking if I was okay, because sometimes these things happen. They might put the BP in wrong, or the weight in like incorrectly. They read the oximeter probe upside down and put the readings in upside down. So people were on the ball. We know if the readings, because basically the alert. Next slide, please. And just really, this is just enablers. So this is really just what you need in place. We had lots of challenges. It wasn't an easy process, but now that we've established it, it's like it just flows really well. You've got to have your SOPs, you've got to have your adopting a collaborative approach, you've got to have a dedicated coordinator for support, you've got to have regular team meetings, and we have lots of meetings with all of the teams that involved. Positive working relationships, the role of the digital champions being pivotal, really. Embracing new ways of working, and keep pushing with the team that this is going to work. This is going to be really help the patients, carers. We do a patient satisfaction survey as well, and that's coming out very positive. And just provide training and education for everybody involved, which we did right through the process. Next slide, please. And just key learning is the same things, is just to get everything, really learn from other sites. If anybody was thinking, oh, this might work for us, learn from other sites. The NHS England don't do the Managing Heart Failure at Home project anymore. They're not giving them, there's no like money available. So I think it's working with other sites that have actually gone through the process, and learn from them around things like sort of not discriminating against age, making sure that all of the like sort of clinical governance stuff's in place, and just engaging with other services. Next slide, please. And that's just some support and resources. It's been a really quick presentation, that there was probably lots more to talk about, but it'd probably be more clear if you read the presentation step by step. But if anybody's got any questions.
Thanks, Trudy. Fantastic presentation. Really clear, really comprehensive as well. I know you've flown through it. You probably could have spoke for an hour on it with all of the learnings. And I think you've covered a lot of it, really. There was one question in the chat around the age range of the patients, but then you've covered that 30 to 84. I was going to have a question that focused on patient feedback on the service, but then again, you've covered that, which is great. In order to keep to time, I'll not open it up to any further questions because I think you've covered it mostly. But would you be happy to put your email address in the chat, Trudy, and then it just means that anyone can contact you if they have any follow-up questions or if they think about something later in the day.
No problem.
That's great. Thanks. Thank you
Thank
so
you.
much, Trudy. So
Thank you.
I'd like to hand over now to Stephanie Wright, cardiology clinical nurse specialist at County Durham and Darlington Foundation Trust, to speak to us about heart failure cardiac rehab. Thanks, Stephanie.
Hi everyone, and thank you for asking me to come and speak today. So I'm Steph Wright. I'm a cardiology clinical nurse specialist for CDDFT, and I work for the CHD and Heart Failure Community Service, and we're an integrated service, and I'm also the BACPR Honorary Secretary. This session is going to look at heart failure rehab and how we can improve outcomes through multidisciplinary care. Next slide, please. So first, just let's look at the epidemiology and the impact of heart failure. And I'm sure that none of this is particularly new to the audience today. But there's 64 million people globally living with heart failure. And in the UK, we've got over 900,000 people with heart failure, 200,000 new diagnoses a year, a one-year readmission rate of 35%. The average length of stay for heart failure is 10 days, and the average cost per year for heart failure admissions in the UK is 25 million. So with all of that in mind, the cost to the economy, the health service, and the impact that this has on the patient that has heart failure, what else can we be doing to help support these patients? And one of the things is heart failure rehabilitation. Next slide, please. So what is cardiac rehabilitation? So this quote is from the BACPR, and it states that cardiac rehab is the coordinated sum of activities required to influence favourably the underlying cause of cardiovascular disease, as well as to provide the best possible physical, mental and social conditions so that patients can, by their own effort, preserve or resume optimal functioning. And that through improved health behaviour, they can slow or reverse the progression disease. The core components of a cardiac rehab programme should include health behaviour change in education, lifestyle risk factor management, psychosocial health, medical risk management and long-term strategies. Next slide, please. So specifically, if we're looking at heart failure rehabilitation, research shows that the following groups should be offered a cardiac rehabilitation programme, and that this is evidence-based. And you can see the list there on the slide, and that heart failure is specifically recommended based on evidence. NICE go on to suggest that people with heart failure should be offered a personalised exercise programme, and that it should be preceded by an assessment to ensure that it's suitable. It should be provided in the format and the setting that's easy accessible, and there should be a psychological and educational component. Next slide, please. So with all of that in mind, in 2019, the NHS 10-year plan included increasing access and uptake of cardiac rehab specifically for heart failure patients to 33% by 2029. 33% doesn't sound very high, but at the time in 2019, heart failure rehab uptake was as low as 4%. 2024 data from NACRA, so that's the National Audit for Cardiac Rehab, that showed that uptake for heart failure rehab had increased to 13%, so an improvement, but still very poor numbers nationally. Locally, our ICB did some bespoke data collection around heart failure rehabilitation, and this looked more favourably that in the North East and North Cumbria, the uptake was around 46%. However, there is some caveat around the accuracy of this data, because it was quite difficult to access via the different services using different IT systems. However, I have worked very closely with all of the cardiac rehab teams across the North East and North Cumbria, and I do know that uptake is higher than the national average. The problem that we've got is inputting our data into the NACRA database across the North East and North Cumbria, and that is improving, but without that data being inputted into NACRA, it just doesn't reflect accurately on what is actually being delivered in the North East. So data's key. So NHS England provided some service development funding, and this was across a number of years from 22 to 24. And that was with this NHS 10-year plan in mind, and that goal of increasing the rehab uptake, but specifically for heart failure to 33%. And then moving into the most recent financial year, the ICB continued with that service development funding. So that funding was actually used to upskill staff in cardiac rehab teams. It helped train them in the delivery of the REACH HF manual, and it also provided the resources to deliver the manual. It helped provide additional staffing to help increase capacity for cardiac rehab. It helped support the cost of venues so that classes could be out into the community, so closer to home for patients. And it specifically was used to try and help teams to with their data input into NACRA. But this is difficult because to continue with this, because obviously all of this service funding is non-recurrent. So it does mean that then continuing with this can be quite difficult for some services. Next slide, please. So the goals and indications and eligibility for heart failure rehab. Well, research shows that heart failure rehabilitation improves exercise capacity and daily functioning. It reduces symptoms. It lowers readmission and mortality rates. It enhances quality of life, and it encourages long-term management. In terms of eligibility, it's recommended for stable heart failure patients with reduced ejection fraction and with mildly reduced ejection fraction. And that's newly diagnosed patients or patients that have had a recent decompensation but are then stable. So there was a school of thought that patients had to be fully optimised before that they could attend a cardiac rehabilitation programme. But actually research has shown that that's not the case. And as long as patients are stable, they can be optimised alongside attending a cardiac rehab programme. So that means that they can access programmes sooner. And I've just put a link there with the details of some ongoing research that's actually looking at cardiac rehabilitation in the HFpEF population. And that's looking at the delivery of the REACH HFpEF trial. And currently, the evidence that's coming out of there is actually supportive that this cohort of patients also are getting the same benefits from a cardiac rehabilitation programme. So contraindications for heart failure rehab include acute decompensated heart failure. So as I've already said, patients have to be stable. Any uncontrolled arrhythmias, anybody with severe valvular disease, and uncontrolled hypertension. Next slide, please. So a cardiac rehabilitation programme should be delivered by a multidisciplinary team. And this can include cardiologists, heart failure specialist nurses, cardiac rehab specialist nurses, physios, exercise physiologists, exercise instructors, healthcare support workers, dietitians, psychologists, counsellor, pharmacists, social prescribing. Wouldn't that be lovely? And yeah, ideally, we would like all of those professionals within a cardiac rehabilitation programme. Unfortunately, the majority don't have access to all of those professionals. However, all cardiac rehabilitation programmes should cover or have the ability to refer to aspects that, for example, dietitians, psychologists, pharmacists could deliver as part of a cardiac rehabilitation programme. Next slide, please. So let's look at the phases of cardiac rehabilitation. Historically, they were described as phase 1, phase 2, phase 3, and phase 4. But more recently, we're describing them as early phase, core phase, and maintenance phase. And this is because these phases and the terminology fits better with the new commissioning guidelines for cardiac rehab. So you've got your early phase, which is that early mobilisation that's often done in the hospital setting as an inpatient, that can be delivered by the cardiac rehab in-reach team. You've then got your core phase, which is the structured supervised phase of cardiac rehabilitation. And then long term, you've got your maintenance phase, which is where those patients go off and continue with those skills that they've learned within the supervised structured programme. So recommended guidance for activity and exercise is aerobic exercise 3 to 5 days a week for 30 to 60 minutes, resistance exercise 2 to 3 days a week at a low to moderate intensity, and then including some flexibility and balance, so some stretching, yoga, tai chi. However, during the structured core phase of cardiac rehabilitation, this is prescribed based on patient, individual patient ability, which can then guide them through into that long-term maintenance advice. Next slide, please. So every cardiac rehab and heart failure rehab programme should have an education component. And there's a list there of the various educational topics that should be covered as part of heart failure rehabilitation. And how this is delivered can vary from programme to programme. And having worked with various teams across the North East and North Cumbria, I know that teams do deliver it differently. So some provide booklets, such as like the British Heart Foundation booklets, Pumping Marvellous booklets, as their educational component. Some provide face-to-face educational sessions. One of the trusts has recently developed some QR codes that patients are able to scan and then access education content on their devices. If patients have access to the digital apps such as My Heart app, there's a really good educational component as part of the app as well. Next slide, please. So cardiac rehab has anecdotally been seen as an afterthought in cardiac care, a Cinderella service, if you like, but also more so in heart failure care. However, the growing evidence now suggests that cardiac rehab should be the 5th pillar of heart failure care and included in that management plan. And these two articles support that school of thought. And I think this diagram really represents the importance that cardiac rehab has and can play in heart failure management. You can see there it's class 1 level A recommended, like drug and medical device provision. So it should be offered universally, but it isn't yet, despite the evidence supporting it. Next slide, please. So just to give you an idea of how we deliver heart failure rehabilitation within CDDFT, the patient identified is identified and referred to heart failure rehab by the heart failure specialist nurse. They receive a phone call by the exercise facilitator, and they attend for a pre-assessment and a functional capacity test. And then based on this assessment, and they are triaged either to the standard cardiac rehab programme or a low intensity cardiac rehab programme. So the standard cardiac rehab programme runs for 8 weeks, twice a week. The low intensity programme runs 12 weeks, once a week. There are also home programme options. We've got the ability to deliver the Reach HF manual, and we also have access to the My Heart app. So patients can have either or both and have a hybrid approach where they can access face-to-face rehabilitation and have access to a home and an app programme. So during the cardiac rehab programme, patients are continually assessed, and the medications can be titrated as required because our cardiac rehab programme contains specialist nurses that have their non-medical prescribing. So patients can be optimised alongside attending the rehab programme, which also then can reduce the number of patient visits that they need. For example, they're not having to see a heart failure specialist nurse for titration because the cardiac rehab specialist nurses are able to do that as well. And on completion of the programme, they'll have a post-assessment and functional capacity test, and then they'll have onward referral to the various options that we've got. So, for example, we can refer on to local leisure centres. We've got specific phase 4 cardiac rehab long-term maintenance programmes available across our locality. We also have really good links with the hospice across our locality that provide certain services such as, you know, chair-based exercise programs, Tai Chi, acupuncture, so we can access and refer on for things like that as well. And then at the end of the programme, they're also referred back to the heart failure specialist nurse. Now, I will say that our service is an integrated service, so we're one team. So in our team, you've got your heart failure specialist nurses, your cardiac rehab specialist nurses, and your exercise professionals, all as one team working together, which does make this process a lot more seamless. Patients get seen and referred to cardiac rehab quicker than historically they did when we were separate services. Next slide, please. So I've got a couple of case studies here. So the first case study, we'll call him Bob. Bob is 65 years old and is a newly diagnosed severe LVSD with an ejection fraction of less than 35%. He's got a history of type 2 diabetes, hypertension, and previous alcohol excess. He had his first review by the heart failure specialist nurse, and his medications at that point were Ramipril 5 and DAPA 10. He was provided with education and a clinical exam by the heart failure specialist nurse, and he was found to be NYHA 2 to 3. And at that first review, he was started on bisoprolol 1.25 and referred to cardiac rehab because he was assessed as being stable. He received a phone call by the exercise facilitator and a pre-assessment was booked in. Before he had his pre-assessment, he had a second review by the heart failure specialist nurse and they started a Plerenone 25. He then attended his pre-assessment and he did a functional capacity 6-minute walk test where he walked 130 metres. And he did his had depression anxiety score was 7 and 6. And based on his pre-assessment, he was triaged into the standard cardiac rehab programme. So he attended the full 8-week programme, and during that time he was optimised. So he was switched to Entresto and he was titrated. At his post-assessment, at his 6-minute walk test, he walked 420 metres, which is an increase in 223%. I've used Bob as our case study because that's the highest percentage increase that we've ever had during our heart failure rehab programme. From a medication perspective, he was discharged on top dose Entresto, bisoprolol 5, Plerenone 50 and DAPA 10, and his blood pressure and heart rate are documented there, NYHA2, but specifically his depression and anxiety scores had also reduced. On completion of the programme, he was referred on for long-term exercise at the local leisure centre and he was referred back to his heart failure specialist nurse, but ultimately the confidence and the benefits that Bob had were significantly visible following him attending the rehab programme. So next slide, please. So case study 2, we'll call Sylvia. So Sylvia is 77. She was referred to cardiac rehab by the heart failure specialist nurse following an admission with decompensated heart failure, which was now stable. She was a known severe LVSD with an ejection fraction of 33% and had an ICD in situ. A known heart failure for many years with a history of ischemic cardiomyopathy. So she received a phone call and was booked in for pre-assessment by the exercise facilitator, and she did a 6-minute walk test. She only managed 50 metres. Now we need to bear in mind that Sylvia walked with a 3-wheeled walker and was NYHA 3. So that walk test, there was lots of stop-start because she had to sit and rest and let her breathing recover in order to carry on. She was on optimum medical therapy, 4 pillars plus frusemide. Her anxiety and depression scores were quite high at 10 and 9. And based on her pre-assessment, she was triaged to the low intensity class. And she was also, following a discussion and consent, referred to our local therapies that we have in our locality, which is Talking Changes. So she completed a 12 weeks once weekly programme alongside having CBT with Talking Changes. And at her post-functional capacity test, 6-minute walk test, she managed 110 metres, which still isn't, you know, a lot, but it's 120% increase to what she was doing before. And again, her depression and anxiety scores had reduced. So we referred Sylvia back to the heart failure specialist nurse for long-term follow-up, but she also was keen to attend the Tai Chi at the local hospice, and we referred to that. And again, specifically, in attending over the 12 weeks, it was very visible that Sylvia's confidence was growing and she was a lot more comfortable. And the feedback that we got from Sylvia was that without attending, you know, she also felt that not only did physically she improve, but also psychologically, but socially as well. She got an awful lot out of the programme, hence why she was keen to be referred on to the Tai Chi. Next slide, please. So what are the barriers to implementation for heart failure rehabilitation? Well, availability and resources. So I know that back in 2021, when I was working with NHS England and we were looking at that service development funding, that there were a number of services across the North East and Cumbria who didn't have access to any heart failure rehabilitation due to various issues, but one of them was down to cardiac rehab services not actually being commissioned to deliver rehab. Another was due to the resources and the capacity that cardiac rehab teams were under. Referral rate is often a barrier to implementation. So sometimes, for example, heart failure nurses who are looking to refer to cardiac rehab may think that patients aren't actually suitable for cardiac rehab. And then this can fit into that knowledge for staff particularly, is that there's not an awareness of what the programme actually involves and what the offer is, for example, in terms of for those frailer, less mobile patients. And again, transport and cost is always a barrier to uptake for cardiac and heart failure rehabilitation. Next slide, please. So how can we overcome these barriers? So where possible, if patients have the ability, can we incorporate heart failure patients into our standard cardiac rehab programme? Can we expand as teams our home and digital options by providing the offer of the Reach HF programme and also using content like the Pumping Marvellous and BHF Online, which have excellent resources for rehabilitation for heart failure patients? The integration of heart failure and cardiac rehab teams, can they work more closely together? Can this help improve working relationships? It can help improve education, but the audit's the big thing as well, and getting that data and those heart failure patients referred and ensuring that data gets input into the national audit. In terms of transport, we're lucky in CDDFT that some of our areas can access volunteer drivers, so that can bring patients to, so have you got access within your service to use volunteer drivers? And then also utilising the ICB specialist groups that we've got. So within North East and North Cumbria, there's a very active heart failure and cardiac rehab group that runs, and also using services like Health Innovation, who are putting on these webinars and helping, you know, the education across the North East and North Cumbria. I will say, sorry, I'll just add to this. This morning, I've also just attended a service scoping meeting with the ICBs, looking at the possible integration of cardiac rehab and pulmonary rehab, and looking at the possibility of in the future, is there the possibility for these services to be more integrated and look to develop kind of breathlessness rehabilitation pathways. And again, some of the services across North East and North Cumbria, I know North Tees and Hartlepool, trialled a breathlessness rehab in combination with a pulmonary rehab team. So again, there's those options that may be available in the future as well. Next slide, please. So key takeaways. Heart failure rehabilitation is evidence-based and should be provided via an MDT. It can improve function, survival and quality of life. It should be a standard component of heart failure management, that fifth pillar, and it should always be personalised. Next slide, please. Thank you. So a bit like Trudy said, very much a whistle-stop tour of what heart failure rehab is and the indication regarding it. If anyone's got any queries or questions about it, I've put my email on there, and I've also put BACPR's email on there. Obviously, the British Association for Cardiac Rehab have lots of resources, lots of education and training available as well. So a really good resource as well. Thank you.
Thanks, Steph. Brilliant. Really, really great presentation. You've got a couple of questions. We've got a couple of questions in the chat, and I think it's worth spending a couple of minutes on them. One of the questions from Leslie was around long-term maintenance programs. So does, after discharge from cardiac rehab, so does that look like like sending them to a leisure centre, or does it look like anything else?
Yeah, so it depends what locality you're in as to what is available, and and it is very different across the country. So ideally, you would like every area to have these phase 4 that we can refer on to that have got BACPR qualified instructors that run them, but unfortunately there isn't that option across a lot of areas. I know that in our area we work quite closely with our local leisure centres and have the option for the exercise on referral, so that then they can kind of follow up and continue with that. And again, like I said, we've got good links with our hospice, and there are other local resources that our exercise professionals have gone out and sourced across the area and deemed appropriate for referral to our patients. The thing with the long term is it's obviously there's always a cost associated with that as well, and particularly if you've got somewhere with phase 4, they tend to not be as expensive as your kind of generic programs. So yeah, but it's very patchy and very different across the country.
Thanks. And the other question is a bit around funding for rehab. Is it still a problem? You might be able to touch on that. And then the second part of the question focuses on whether patients are given information on heart failure rehab after discharge or on discharge.
Yeah, so I think funding is always an issue in whichever area of healthcare you're working in. But yes, so from a cardiac rehab perspective, there was service development funding, but obviously that's non-recurrent. So what we have seen is that without that non-recurrent funding, for example, if it's financing staff venues, then without that funding, often trusts aren't able to then continue to provide that. Having attended the meeting this morning with the ICB for North East and North Cumbria, there will be a pot for funding for the next financial year, but how that looks might be quite different, which is why today we've had members of the cardiac rehab and pulmonary rehab teams attending this session today. And with regards to the second question, it depends on whether the patients have got an InReach cardiac rehab stroke heart failure InReach service. So if your heart failure patients are in hospital and they're seen by an InReach heart failure nurse, then it may be that cardiac rehab is discussed at that point in time. And also it differs from service to service. So some heart failure patients might be referred to the rehab team, and if they've got capacity, they'll see them as an inpatient. Again, we're quite lucky because we're an integrated service, we're all one team, so we're very aware of those patients, and it has made a huge difference.
Brilliant. Thank you. Thanks very much, Steph. I'm sure, as you said, you've got your email address there. If there are any further questions you've mentioned, you'd be happy for people to email you. So thank you very much, Steph, and thank you very much, Trudy. Thank you very much for everyone who has stayed on the call. It's great to see so many people with the interest in these areas. If you've got any topics that you'd like us to cover in future webinars, you can email myself or Christine. I'll put my email address in the chat, and we'll make this webinar available. We'll ask permission to be able to share the slides as well from the presenters. But enjoy the rest of your afternoon, everyone, and thank you for attending this webinar. Bye-bye.